So I want to pivot a little bit onto the subject of language. So we know for everyone living in rare disease how important using the right language is, and it's, the complexity of that. And that can be, really from using native language to the use of medical jargon, lay summaries. But deep, what are the challenges for you when it comes to the sort of finding common ground within a clinical setting for language?
I think one of the challenges is this condition is rare. It's also in terms of the classification. If you could have made anything class difficult, this is it, because we've added bits on. We've added bits on. So, you've suddenly gone from cutaneous mastocytosis urticaria pigmentosa to mastocytosis in the skin with four different definitions medically. You've gone from indolent systemic mastocytosis and aggressive to now a spectrum of non-advanced mastocytosis and advanced mastocytosis. So from a clinician perception, looking at the guidance that most clinicians would look at on the WHO, this is mushroom, but more and more terminology. But we're also overlapping terminology, non-advanced and aggressive, indolent and aggressive symptoms. We really need to be careful because I'll give you an example. When I first started on this, and I saw a patient with anaphylaxis, and I did probably my third marrow, and said, "Oh, you've got indolent systemic mastocytosis. The data shows you've got a normal life expectancy, and it's not aggressive." That's medical terminology. And I had a patient sit there saying, "Really, I could die tomorrow with an anaphylactic reaction. That's aggressive, and it shortens my lifespan." And it was a real learning curve for me because it was, hang on a minute, I've turned this life expectancy Kaplan-Meier curve, but I've not looked at the patient in front of me. And I think that's really important. I think the classification is dramatic and it gets worse, c-KIT mutations, blah, blah, blah. So these days when I see a new patient, I will decrunch it because everyone comes from a different perspective and everyone's gone on the internet and the understanding is from their point of view, depending on what they've been given. And I'll ask a patient what they know. And I turn most things into as much lay jargon as I can, explaining it in the context of that patient and their symptoms. So I kind of have, with experience, I have three areas that I walk through. What's bothering you? What do you understand? This is what I find of your diagnosis. And I do tend to share the tryptase levels and results on the screen that are pertinent to them. And I explain the bone marrow for them to understand it because we put that in. And then I try and explain where they are in that classification. And then I come back and say, now you hopefully understand that a bit better. Let's talk about you.
Yeah.
But that takes time. And I have to say that, that means that patients should need more time for that first visit. That's looking back at what we need for these very rare conditions to enable patients to have that information given in a way that they can understand it in a time, not a time locked situation. Because when
And going back to that, it's that awareness, isn't it? That you're recognizing that not every patient is coming. Some will consume everything on the internet, some will take very little on board, and meeting them where they are and recognizing that, it's so often that we would just see sort of these phrases being thrown at us without any regard for whether our level of understanding is sufficient to take that on, or even our emotional well-being at that time is able to receive what's being said. So I think that's such a high level of awareness to have that. I
and
touched on something there about the internet, and I know this is something you feel really passionate about, Jess, in terms of AI and the wealth of information that's on the internet. With the rise of AI, do you feel that that is helping or is it hindering patients with all this crossover and different categorization? Any thoughts on that?
I think there are good things and bad things. And, the good is I've seen a couple of patients in chat groups around the world who said, I put my symptoms in and it came out with this, and that it was mastocytosis, and I pursued it and got diagnosed. So that's pretty cool, right? And I know my sister is a nurse practitioner in the US. And when she goes into her electronic health records system, she said it now will pop up and say, we see a constellation of symptoms that looks like this rare disease. And here's who knows about it in America.
Wow.
So that's amazing, right? If you could do that. And it's the same system that's being used at Dipti's hospital, but I don't know that you have that function. Um, so there's great potential there. And I know there are researchers who are looking to try to really pin down what are the symptoms you'd need to see to really strongly suspect mastocytosis so that you can develop those models that would then be really helpful to the less experienced doctor if that were integrated into the process. I do worry because, we get patients who will have, they'll share something in our Facebook group that says, something that was produced by AI that is not correct. And obviously we correct it in that setting, but that people will be doing that in a circumstance where they won't correct it. I've had people send me summaries and say, is this correct? I wanted to share this with somebody. And luckily I took a look because it was sharing incorrect information. And sometimes, of course, and this has always been true, people, because it's such a complex diagnostic process, you can think you're somewhere else in the span of of seriousness, and mistake yourself for being in a usually a more dangerous situation than you actually are, because it's quite rare to be on the
But do
more
you feel an increased sense of responsibility as an advocate and someone who's overseeing these group and chat environments to sort of sense check that now, where people are not necessarily drawing on source research material, but this kind of accumulation of it generated through AI? Does that give you a bigger job and a bigger anxiety on that type of content being shared?
It does worry me. And when people share it, I check it, and I will bring in a link to an appropriate article and explain where it's gone wrong. But it's extra work,
Yeah.
but it's important work.
Can I
Is
just,
that something you see clinically then, Deepta? Are you seeing
I was
people
going to
come
say, people
generating?
will come in and
Yeah.
will have gone along AI, they'll have Googled their symptoms. And like Jess, I think we've got a lot to learn from harnessing from AI, but it's got to be appropriate. And I think looking at intelligently, there's AI intelligence, there's emotional intelligence, and looking at it intelligently to get those possible clusters of symptoms in context with other tests, which are objective, to get people in the right place. The challenge with mastocytosis, as we said at the very beginning, there's a massive spectrum. And if you put all the symptoms of mastocytosis in, you will get multiple differentials. We've talked about gut symptoms. That might be inflammatory bowel disease. We've talked about urticaria. That might be a different reason for having hives. We've talked about big livers and spleen. That might be completely different. And the challenge is it's really systemic, as in total body symptoms. So if people just put their symptoms in, I have patients approach me. I've actually had it in the reverse where somebody said, I don't believe I've got mastocytosis because they didn't want to. I think I've got inflammatory bowel disease because there's a treatment for it. And you go through the symptoms again, but then actually mapping it to say, your tryptase is this. We have found mast cells and you have a c-Kit. So although, you know, you're not in a bad place, but that is the diagnostics. So I think actually pulling that all together with the symptoms with the objective diagnostics is the way to move forward. But I think we've got to harness it. And I think, like Jess, I'm a little bit scared about the context and the interpretation or the misinterpretation. And that, I guess, comes with the role of moving forward to this wonderful system where you can get information, is again, learning how you harness it, learning how you try not to be scared of it. And it can be scary, and pulling it out in context with that particular person. Otherwise, I think it can weigh quite heavily sometimes.
And just expanding on that, what are the clinical biomarkers for sort of severity of disease, and how do you translate that? You sort of mentioned a bit earlier about, the patient experience versus the results. How do you translate that, and what adaptations would you make to language to suit?
Okay, you're asking me? Okay.
Yes.
So the basic biomarkers, we have a blunt biomarker that everyone uses. It's peripheral blood. It's not invasive. It's a tryptase. When your mast cells are triggered by something and you release what's in the mast cells, and I'm going to call them packets of mediators, but they are a whole load of mediators that cause inflammatory responses wherever they go to. So although your mast cells may release in the skin, they have distant effects. So they release tryptase. So a patient with mastocytosis will have a baseline tryptase. That will reflect the amount of mast cells in their whole body, not the liver, spleen, and the skin. When they have reactions, that tryptase will go up. You'd expect it to go up because the mast cells are releasing more. So that's our kind of baseline marker. If you get more disease burden, which means it's more in the liver, spleen, the tryptase is higher. But just because you've got a very high tryptase doesn't mean you've got aggressive disease, because if you've got lots of skin disease, that's where the tryptase is sitting from a mechanical point of view, and your spleen and liver might be perfectly normal. So the tryptase is a fairly blunt but a good indicator. It's one of the classifying markers, and you then have to see the patient to do it in context. And then from the other markers, we don't do, there are urinary markers, but we don't have validated tests, which we use here in the UK. There are very few centres that have that. We have diagnostic tests. So then to make the diagnosis, we invariably look at a biopsy of a bone marrow to confirm that those mast cells are abnormal mast cells and they're clonal. Because you can have a condition which causes a lot of inflammation in your skin, and normal mast cells release tryptase because that's what happens. You can have no skin rashes and you have a wasp. If I got stung by a wasp, my mast cells would come out and my tryptase would go up, whatever the baseline is. So it's actually putting it into context. So the diagnostic bit for systemic is a tissue sample showing that there are these abnormal clonal mast cells. They look different. They have specific markers that tell us that they are different. And we have this c-KIT mutation that we identify, which is not abnormal for patients with systemic mastocytosis. It's perfectly normal. We expect it in 95% of patients because that's what drives the disease and tells these mast cells to divide. That's diagnostics. Then how that plays in a patient is the whole thing we talked about, the symptoms, really.
So that translation of what they're seeing versus what they're experiencing is so important. And something that really struck me when we spoke before, when we were doing the interview for the edition, was about the sort of the terminology of cancer. So, mast cell diseases can come under a cancer diagnosis. And I was really interested in how you have a sort of nuanced view to how you communicate that with patients. Can you kind of expand a little bit on that in terms of how you would use the language of cancer and how you might change and tailor that to different patients and for the different reasons that you do?
Absolutely. So, cancer definition is an abnormal cell driven by a mutation. That's the definition. That's, and that's why it's a cancer. We've got a KIT mutation. But, you have low-grade cancers in patients. Moles can be cancerous, but they're low grade. They get removed. So for me, it's really difficult when you've told somebody they've got indolent mastocytosis and they've got a normal life expectancy, but by the way, you've got cancer. All that information is too much. So I may not use that terminology initially. I'll use terminology like abnormal mast cells, clones, dividing. But I do think patients need to be aware because they'll go off and Google and it will come up with cancer. So I do make sure in that first one, depending on the patient, I will talk about abnormal cells because there's mutation. They're defined as being a cancer. And then I'll pause, and then the patient will either want to hear it or not. And I'll give them space to ask me the question about what that means. And I tend to do something that's ridiculous and it's unique to me, is I kind of put my arms out and go, here are low-grade cancers, here are high-grade cancers, and you are over here. And then I'll go and talk through it just because I was sitting in with somebody who was given that diagnosis and a clinician did that. And she kept going, he went to the left and it was low grade because nothing else went into the person's brain, but they remember that. And so it's nuances, but I think it's really important. And also to say, we do have low grade cancers. The important thing is we know what you've got. We know we need to monitor you. We know we need to treat you and we know what to do. So let's move down that journey, but give people space and time to do that. And the other thing in the UK, which is unique, and I hope it lasts a little bit longer, is that if you have a diagnosis of a cancer, you're exempt from getting your medications. And some patients, although they have indolent disease and non-advanced disease, are on 7, 8, 9, 10, some up to 11 combinations of anti-mediator therapies, and each prescription costs money. So it's not about saying you can't afford it. It's about saying there is some help you can get if you need it. And I think that's important, and it's particularly specific to the UK. And like I say, long may it last.
So it's important to introduce that language. So I guess there's no surprises if they see that in documentation, but also that they're able to access pathways and support that might
For
come.
medications, if they choose to do so,
Yeah.
and it's standard. So it's somehow introducing that. And also for me, when I've said that, I'm very lucky in my service that I have a fantastic team and a clinical nurse specialist, because if I see a patient who, who probably needs to talk to somebody else, they've seen the doctor that's now said, oh, cancer, then all of our new patients at some point get a conversation with our CNS because they're talking to somebody else and it's different words and we work together. And I'm very lucky to have that. Most cancer services have a CNS. So, even if folks are seen in an MPN service, they will have that access to that, but it's about experience and understanding as well.